everyone, and thank you for taking the time to join us to kick off the special PQMD COVID-19 Pillar Talk webinar series. Normally, at this time of the year, the PQMD community is gathered together at our Global Health Policy Forum. This is a convening that is dedicated to providing a space for thought leaders and global health practitioners, both internal and external to the PQMD community. And together there we discover and share unique perspectives, provocative positions, and innovative ideas to inspire and inform the action in our shared global health workspace. When this year's meeting focus and function shifted due to the situation around us, we began planning for this webinar series. Individual sessions will be devoted to health workforce, diagnostics, supply chain, and product donations, vaccines, health security, and therapeutics. Today, we'll be discussing the global and local health workforce challenges, and we're going to focus in on surge planning, capacity needs, systems innovation, equity, and information management. My name is Julie Marie Vanderberg. I'm the Senior Director here of Global Health at PQMD, and I wanted to welcome you together with the entire PQMD team to today's webinar session. For those of you who aren't familiar with PQMD, we're a global alliance committed every day to advancing the role of product donations worldwide. And today, the work of our members is central to the international response to coronavirus. Their activities are spanning from securing critical supplies to training healthcare workers, supporting facilities in screening and testing needs, developing and distributing diagnostics, investing in vaccine and therapeutic development, and donating cash where it's most needed. With 41 members representing leading international and US-based NGOs and global healthcare companies. We were founded in 1999, and our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster and response preparedness, guidelines and standards, and knowledge management. By virtue of our trusted network, our members leverage their partnerships, expertise, and resources for impact, all while adhering to the highest standards of excellence in donation practices. And we couldn't be more proud of this network during the COVID-19 crisis. Before diving in, I just wanted to quickly review some housekeeping rules for the webinar. So welcome again. Now go ahead and warm up your fingers. Type in the chat box, please, and let us know and let the audience know who's out there and what organization you represent. We're going to be using the chat box here today for question and answers as well because of the size of the audience. Be sure, please, to put your microphone on mute and turn off your videos. This session is being recorded to share with other members of the PQMD community of practice. This webinar is going to consist of about a 40-minute dialogue with some time baked in for question and answers. So go ahead and put your question and answers in the chat box, and we'll try to get to some of them, and the rest of them we'll address on the community of practice. Also, I'll float the link for our community of practice into the chat box. Be sure to join us and to follow up on this webinar, but also for more information on our series of webinars and all of our PQMD happenings. Now, there's been just one change to the program today. Dr. Azza Karam from Religions for Peace is not joining us today because in discussions with her to prepare for this session today, we covered so much ground that she graciously agreed to host an entirely different session on the influences and forces that contribute to health security. So we'll get you more information on that. But therefore, now I have the pleasure of turning it over to EJ Ashburn, PQMD's Executive Director. She has over 2 decades of experience in global health. She's worked at the World Bank and in private consulting in the areas of public and private sector partnerships, global health financing, infectious disease, and health management information systems. EJ leads the PQMD staff and supports the membership through her strategic vision and strong networking focus. She'll lead us through today's session, and she also has the pleasure of introducing our speakers. EJ?
Thank you, Julie Marie, and welcome everybody to this webinar. This is going to be a great hour, and we also want to hear from you. So make sure that you start thinking about and jotting down your questions and use the chat box as Julie Marie had mentioned. As we all know, healthcare professionals are incredible living assets leading the battle on the front lines of COVID-19. Our experience has shown that healthcare workers are uniquely affected by a cascade of critical shortages in information, personal protective equipment, diagnostics, ventilators, and facilities. Healthcare professionals are faced with difficult decisions in extremely high-stress environments within the framework of ever-emerging empirical knowledge and best practices related to COVID-19. In an effort to support the global health workforce and health systems through the global health work in which we all share, today we will discuss what is known about how the workforce is managing under these conditions, explore strategies for surge preparation, best practices in knowledge management, and addressing training needs. We give unique focus to considerations for lower and middle income countries, and we'll also explore if there is a critical learning to apply from past epidemics and crises, which so many of our members and all of you, I'm sure, were involved. I'm thrilled to be moderating this fantastic panel, and I'm going to ask each of them to please introduce themselves in about 2 minutes. And I'm going to start with Dr. Talenko, or Kate. Please introduce yourself.
Hi, yes, and good afternoon to everyone. I'm so glad you're able to join us. So I'm Dr. Kate Talenko. I'm a physician in health systems and health workforce specialist, and I'm the former coordinator of the World Bank's Africa Health Workforce Program and the former director of USAID's Global Health Workforce Program. And I'm currently now supporting Operation Smile in their health workforce strategy.
Thank you, Kate. Dr. Jean-François.
Hello, thank you for joining us for that webinar. I'm Diane Jean-François. I'm a physician, I'm a pediatrician, and I have a master in public health. I've been the country director for 16 years now for the Catholic Medical Mission Board. I've been working in different settings in Haiti, working on HIV, AIDS, TB, leprosy, access to primary health care, malaria, and anything that can better the well-being of the Haitian population. So we work also in livelihood, agriculture, and we health system strengthening, where we have built a hospital just to provide quality care to people living in the southeast of Haiti. Thank you.
Thank you, Diane. And Matt, please introduce yourself.
Hi, everyone. My name is Matt Hackworth, and my title is the Senior Advisor for Marketing and Communications for Chorus International. Chorus International is a new organization created by the coming together of Lutheran World Relief and IMA World Health. Lutheran World Relief brings an extensive background in agricultural livelihoods and emergency response assistance. And IMA World Health is a comprehensive public health agency. Both are faith-based, and so I've spent most of my career in the faith-based space. And so that's the manner from which I'll address all of our questions today. It's great to be here.
Yeah, thank you. And thank you to all of you for spending your time with us today. I'm going to start with Kate, and given your clinical and epidemiological background, I'm wondering if you could give us a brief assessment of where we are with the virus today globally and what your projections are on how the workforce is handling the surge in patient needs and the importance, of course, of supporting frontline healthcare workers in this pandemic.
Thank you. So as far as where we are in the pandemic, one of the challenges is that the outbreaks are mainly separate outbreaks. So you have the Wuhan and Chinese outbreak, which are in later stages, and they're currently having very few new cases. You have outbreaks such as in Italy and New York City, where they're just beginning to flatten the curve of new cases and handling the surge. And then you have new outbreaks which are coming up, such as in Brazil, and each needs to be handled in a different way. And I think probably what will happen is most of the outbreaks will trend towards what's going on in Wuhan, fewer and fewer cases, but with little outbreaks everywhere. And the big question is what happens in the autumn when it starts to get cold again in the Northern Hemisphere, and whether, like in the Spanish flu outbreak, there's a resurgence in the autumn. So it's all the more reason why we have to get things right during the next few months. And on the issue of health workforce, needless to say, the outbreaks have been extremely stressful for the health workforce, many health systems and hospitals being overwhelmed. And really the strategy in the short term is to do the surge planning, to make sure you have enough health workers, that they're adequately supported, both physically with PPE and other materials, but also mentally. And one of the things we did in Operation Smile was put together a surge planning checklist that health facilities or other organizations can use to plan the health workforce that they'll need to handle the largest part of the surge. Really, one of the most important things to think about is potentially dividing facilities up into COVID and non-COVID. Because one thing that we've seen is a huge reluctance of people to go to health facilities because of fear that they will catch COVID. And one thing we know happened in the Ebola outbreaks in West Africa is more people died from non-Ebola conditions than died from Ebola because of lack of access to care. So, one potential solution during this outbreak is to have some hospitals be COVID hospitals and other hospitals be non-COVID hospitals. Another way that the patients can be segregated like this is to create respiratory clinics. So these are clinics where anyone with respiratory symptoms, cough, trouble breathing, will go, and you have all the oxygen supplies, and the staff have the PPE to address that. And that frees up your ER to take care of non-COVID emergent and urgent problems. Think of is for health facilities that didn't already have telemedicine units. Now's a great time to start one, because you need to continue to take care of people with chronic illnesses, and also you need to take care of urgent issues and keep people out of the emergency department. So each facility needs to decide what capacity they're going to have in each of their units. What's going to be your ICU capacity? What's going to be your COVID ward capacity? What's going to be your non-COVID ward capacity? And then once you've decided that from a bed point of view, you then need to design your team. Now, traditionally, many physicians will take care of 10 to 20 patients. Nurses will take care of 4 to 10 patients. It varies country by country. But when you're in a crisis situation like this, the American Society for Critical Care recommends a tiered structure to the health workforce. So you're going to completely redesign your team. And just to give an example, in this team, this new team design, one ICU physician would take care of 96 critical care patients. So one ICU physician supervises 4 teams, each headed by a non-ICU physician. And that physician supervises 4 ICU nurses who each supervise 3 non-ICU nurses. So you have this pyramid of expertise where you have the critical care physician on top, and they're able to make the most important decisions around intubation, critical procedures, initiating end-of-life care, and then that frees up the other healthcare workers to do the less complex tasks. And also in this model, there's a respiratory team, which would consist of nurses or respiratory therapists who manage the ventilators and other respiratory requirements. So that's the type of different design change you need in surge planning. Another important consideration is where you're going to get these new healthcare workers. Now, it was originally thought that we would need to pull people out of retirement, but that hasn't been the case, because what tends to happen is because people are avoiding the hospitals, you actually have quite a number of active healthcare workers who don't have enough patients. And in fact, in many countries, you're seeing layoffs because of this. And so you can take these active healthcare workers and bring them to the COVID hospitals. But a lot of this depends on the ability to change licensing rules, or the ability to pay people at a station other than their duty station. We'll cover PPE very briefly here, because it's such a complex issue, and almost no country has had sufficient amounts of PPE. So really the most important thing I can communicate is, in any setting, all patients should be presumed to be COVID positive, and all healthcare workers should be allowed to wear a surgical mask and gloves, even if it's their own equipment. And then, as you get more and more supplies of PPE, you can provide them with more advanced forms of PPE. But at the very minimum, people should have the surgical masks and gloves. We also want to take a look at training. So needless to say, healthcare workers have never taken care of COVID patients before, and you're also having a lot of primary care workers now taking care of critically ill workers. So that's a big step for them. So we're recommending the first part of training is would be like a teletraining, where they're given training via webinar on very detailed elements of the natural course of COVID, how to make the diagnosis, how to do the treatment, the support that's needed. And then if possible that they do some simulation, because it's one thing to know knowledge, is another thing to be able to apply it. This simulation might be case studies, or they might be simulations with mannequins. That's something that's very important actually for anesthesiologists who are having to intubate in the COVID outbreak. And then another critical component is clinical guidelines. Because the way we treat COVID has evolved very rapidly as we've learned more about it. It's essential that on a regular basis, your health facility publish new clinical guidelines so people know exactly how we're diagnosing, how we're treating, are we giving anticoagulants, are we giving antibiotics. They need to know that, because that will give them the confidence so they can provide the best quality of care for the patients. And then I'll just mention a couple other things, and then we'll go on to one of the other speakers. Mental health is a critical issue, and most countries are now setting up hotlines for health workers and others to call in and get support. There's a lot of anxiety, depression, a lot of post-traumatic stress disorder amongst healthcare workers. And we also recommend daily wellness checks with health workers. So health workers on a daily basis, should have their temperature checked, asked if they have any other symptoms, have a check on their mental health, and also a check on how they're able to provide for their families. Like, do their families have food? Do they have a safe place to stay? Because that's been an issue in a number of places with healthcare workers being kicked out of their homes. So I'll stop here, but we'll provide a copy of the surge planning guidelines so that the audience has them.
Yeah, thank you very much. So it sounds to me like among many things, right? We have to be rethinking sort of preparation, planning, rethinking system and delivery structures, supply paths, training, not forgetting, of course, mental health, which always seems to be at the end of the line, but again, these are humans, and our health workforce, it needs to be of sound mind and taken care of with all of these dramatic situations, in particular with their families as well. So thank you very much. That was fantastic. So Diane, let me go to you. You've expressed that being in Haiti, and I'm so glad you were able to join us from the field. We really appreciate that. But being in Haiti requires you to be ahead of the curve in your critical thinking about how to support your community in disaster response. What have been your COVID-19 specific plans to address health workforce training needs, and how will you cope with the surge if and when it comes?
Thank you. I said that I've been the country director for 16 years now for CMMB. So we have learned a lot about disaster preparedness. We have faced and respond to earthquake, hurricanes, and cholera outbreaks. Each one are different. With us, we said that we have received continuous training on site to know how that one needs to be really, really prepared, as we know how weak the health system is in Haiti. For example, as Hurricane Matthew approached, we knew that supplies would be quickly depleted. So around Port-au-Prince, so what did we do? Staff went out before all over Port-au-Prince to buy up supplies. CMMB in Haiti now is currently supporting about 77 health facilities, in which 15 of them are major hospitals. When I said major health facility, that means that they provide obstetrical, surgical, internal medicine, and pediatric services. And that also includes the hospital that CMMB built in the southeastern of Haiti, in the district of Côte de Fer, the Bishop Joseph Sullivan Hospital. CMMB, working with other partners, have adapted different training material in French and Creole about COVID-19 for different health workforce, healthcare providers, and community health workers. It was critical to communicate to the community what is known about COVID-19, what is unknown, and action to be taken on a regular basis. We have gone to the community radio in each community where we work and involved the radio station in sharing information and educating the communities about COVID-19 and hygiene, simple rules, washing hands. The messages have been adapted according to community feedback to detect and respond to concern, rumors, and misinformation. One thing that we know, our people in Haiti, the literacy rate is very low. So it's very important. And the belief also, strong belief is very high. We have used trusted leaders, religious leaders, even one person that had contacted COVID-19 that had been treated and that made buzz. When I say buzz, that's the word they use, that made stories in Haiti, to come with empathic, transparent, and consistent messaging. CMMB, before even we got the first case in Haiti, we have asked all the health facilities to come with a plan about triage, patient consultation, contacting the national lab as testing is centralized currently in Haiti, and also the management of COVID-19 patients before the Ministry of Health can reach that remote area. And also we ask the sites to come with a plan to follow up of contact cases. Preparedness and responses activity have been conducted in a participatory community-based way, engaging not only the authority, but also the leaders, the community leaders in each one of the community, but also religious leaders, Protestant church, Catholic church, traditional healers. It was not an easy task. I can share that with you. Because some of those people, those leaders themselves, they don't believe in COVID-19 in Haiti. They think it's a foreign disease or it's something different. Certain health facility, they have identified all cholera infrastructure that needed some renovation, and they repurposed that structure for COVID-19 or also parts of wards of their hospital. They also positioned some PPE that they had in stock and forecast for more for medicine, medical supplies, and equipment. One thing that we had realized in Haiti, ventilators are not an option for Haiti because we don't have enough healthcare providers with the required skills in Haiti. So that's something we're not even thinking about. CMMB Haiti, we have worked with New York, CMMB New York, and also with suppliers to identify and procure some PPE coming from very far away. Supplies and medical equipment also. Some start to arrive in Haiti, but in slow motion, we know the situation. We need the supplies, not only for COVID-19 patients, but also to continue to provide essential health services. Women are still delivering, babies are being born. We must continue immunization, that's an issue there. And activities to reduce maternal and child morbidity and mortality. Care and treatment at health facility for different other diseases, such as HIV/AIDS, TB, and leprosy must continue. And the worst, there is a risk for the healthcare providers. Any patient could be positive for COVID. We need to share the new information with the health workers. They need to know how to handle COVID positive patients. For example, a pregnant woman that comes to deliver and she is COVID positive or she's not, they need to know that getting a spinal rather than general anesthesia to minimize the exposure to the virus. So those are kind of examples, just like Kate was mentioning. We need to inform the healthcare providers. So we are staying on top of the science and providing additional training to the workers. Thank you.
Thank you very much. So, I mean, Haiti has, unfortunately, probably not a unique experience, but certainly substantial experience with disasters and disease outbreaks. And so the need for planning is something that I think need for pre-planning is something that you're familiar with and that clearly is going on. Also, an important point I think you mentioned is the training materials in multiple languages. I recently saw a map of the United States that had states by most prominent second languages, and it is, you know, there are huge populations that speak Chinese, Spanish, German, everywhere, and so many of them are in the health worker field. So multiple training materials in multiple languages is absolutely key. You also, of course, emphasize the importance of using community leaders, but also making sure that you address perhaps rumors or misinformation and help sort of coerce them into being the positive advocates that they are for their causes. And then, of course, something that does keep coming up is sort of integrating the response into ongoing medical priorities. And I always say that, you know, hurricanes and other disasters and even just regular medical procedures don't actually know there's a pandemic going on. And so you really need to have that in hand and understand that. And that goes back to what Kate was saying about maybe rethinking the systems and delivery structures that we currently have in place. And you pointed that out as well, Diane. So Matt, I'm gonna go to you. So your position at IMA World Health affords a unique perspective on the evolving nature of how NGOs operate, such as the ability of NGOs to typically respond with human capital and life-saving supplies, both of which are in critical short supply, as we've just heard, in the COVID-19 pandemic. That said, we are also seeing an unprecedented new wave of funding resources in the United States. Generosity is certainly abounding. How do you see the confluence within the COVID-19 landscape for particularly lower and middle income countries?
Thanks, EJ. I appreciate the question. I mean, I think in our context where we work in the poorest of the poor countries, what COVID-19 has done is taken a challenging situation and made it even more challenging. It's veritably ripped the Band-Aid off, if you will, and exposing, I think, some of the challenges of working with already weak health systems. As far as Chorus International goes, we've seen a couple of interesting things. First, in our non-public health related programming, we're starting to see some of the resources that are available at the community level leveraged for a COVID-19 response. Some of that takes place with mainly providing support for emergency feeding for families that cannot get out and get to work. In Indonesia, we have coffee programs, for example, that are using their cooperative networks for information sharing about how to stay safe in COVID-19. So it's an interesting question to consider from workforce, if we can put those resources to work just sort of ad hoc, and these things took place at the community level, that wasn't our driving. If we can put them to work in that capacity, how might we incorporate them into the health system moving forward? For our work that focuses on public health programming, most of that is Africa-centric at this point. Our primary means of responding is through the Christian health associations in Africa. There a number of organization is one that IMA World Health helped to create called the Africa Christian Health Association Platform. This represents 43 Christian health associations in 32 countries. And these are the facilities. It's estimated around 5,000 facilities where the most marginalized and vulnerable individuals get access to services. And so what this has done is it really exacerbated that challenge from a workforce standpoint, but also from a supply standpoint. So to build on Dr. Tolenko's well-taken points on PPE And the emphasis on masks right now, so procuring masks is a challenge, not only for our workforce as public health implementers, but also for our partners in the Christian health associations. From a best practices relief and development standpoint, our ideal would be to source those masks and gloves and other protective equipment as close to the source of need as possible to bolster the local economy. But right now, because there isn't really the capacity to produce masks in the quantities that are needed, we're having to draw from other countries. And so, to the point of your original question, what's this doing as far as the disparity between lower middle income countries and those other countries in the global north? The global north countries are really soaked up a lot of the PPE to the standpoint that the market is now challenged to respond. And so that puts those facilities and those frontline health workers who care for the most vulnerable individuals even more at risk.
Right, thank you. Yeah, so working in fragile health systems, as we all do, and perhaps I think many are surprised at where the fragility exists, like maybe in Italy or even the United States. I mean, we're so used to dealing with it in developing countries. So it is definitely presents a challenging situation, and leveraging resources on the ground is something that we hope will happen with marrying the donations and contributions and other financial and technical resources being offered. And then I really think your point hits home, as all of you have mentioned, that there really needs to be a whole community response, because it isn't really only about the medicine. It also has to be about the food. It has to be about access to other resources that are needed during it, because health, of course, doesn't operate in a vacuum. And then something that we will pick up in another webinar, which will be sort of disruptions in the supply chain. But the supply shortages are really something that we definitely want to delve into in the future, just because at the beginning of the outbreak, tons of people were sending massive supplies out of the country, or even out of the countries, not expecting that it would come to their country, and then everyone had to hit it, bring it all back, or they just simply ran out. So that is something that, and the health workers, of course, are at the very core of that dilemma. So it's something that we definitely want to pursue. So I'm going to pause for a moment here and see if there are any questions. Julie Marie, I'm not seeing them, but if you have any questions, if anyone has any questions that they put into the chat box.
You're not wrong, EJ. I don't see the questions just yet either. I have a couple that have come in to me privately, but in the respective time, why don't you keep going, and we'll take another pause for questions. So please go ahead and utilize the chat box or the question and answer box, and we'll get to you. Thank you.
Okay, that's great. Thanks very much. Okay, Diane, back to you. A network and coordinated response can be effective in delivery of important information and resources. What are you seeing now in terms of preparation for surge staffing and knowledge management for COVID-19 across different levels of the healthcare system? So that includes community health workers all the way to tertiary care facilities. You touched on some of that in your previous answer, but maybe giving us a little bit more would be helpful.
Yes, I did. It's all linked together. First, at the community level, there's an aggressive communication campaign to change the people's attitudes and behavior toward COVID-19. It's for everyone, for the community health workers. They have to understand life is different now. They have another approach. Although they don't believe or they don't see the disease like it was cholera, when in the time of cholera, people were just dying, sick, diarrhea, dying. But COVID-19, they don't see anything, just talking, so it's a foreign disease. Although the government has ordered social distancing and wearing face masks, for many Haitians, the normal routine have not changed, nothing. They think COVID disease, like I said, is a foreign disease, and they don't take any precaution. In addition, there is also the societal stigma associated with this illness. Very important, as is often the case in Haiti, for example, for cholera or HIV/AIDS. Not also to forget the economic situation of the population, and also all the problems that existed before. So adherence to prevention message such as social distancing, hand washing, it's not happening. I can tell you it's not happening. The state of Haiti now, it's just like it's normal. People going out, they don't respect any curfew, nothing. So what we are doing, working with the authorities, with the traditional healers, the religious leaders, and trusted people to reinforce the community engagement for social and behavior change approaches to ensure preventive community and individual health and hygiene practice. We also, ensure dedicated hospital beds with well-trained staff and necessary equipment. To go back to what Kate was saying, this is important. As we know, the specialized doctor, the emergency doctors and all, they are mostly in the capital city, not on the countryside. So that's a huge problem. So we are working to train. Currently, there are training going on using YouTube, whatever media that we can use to do that. And this is not only CMMB doing it, it's working with different other stakeholders, working with the Ministry of Health, working with the US mission, PAHO to do that. Another problem is surveillance. Big problem. The rapid response of teams and the case investigation, major problem. So what we're working to do is to strengthen the surveillance department with training for community health workers, as they were already doing contact tracing for HIV/AIDS. So now we have to update them on COVID and how to do it differently. And also the funding needs to be allocated to the surveillance department. And all this is centralized, of course, at the Ministry of Health. That's their responsibility. So it is important for comprehensive, rapid contact tracing and case identification. Yesterday, we in the community where we have built, where CMMB have built the hospital in the southeastern of Haiti, 4 cases of community transmission have been detected. And the reaction of the population was not a good one. They removed their patients from the hospital and they went in the community with the hospital acting like it was a normal, death. They still believe in COVID-19. Even when the authorities came, they did not release the body of that dead person, and also they did not accept to be tested. So I say currently staff are working together with the surveillance department to identify patient 0 in the area and calibrate appropriate and proportionate public health measures in the area of Côte de Fer. A lot of fear going on over there for our staff. As you know, they have positioned some PPE and some are coming, but we have to distribute all over the country. So the lack of PPE and other medical equipment to respond to the fast spreading of COVID-19 in Haiti can put us at a disadvantage. Yeah. Health facilities are often remote from testing location. I mentioned before, testing is centralized in Port-au-Prince at the national lab. And also we have gang activities and the insecurity that are really impacting responses of certain NGOs. And like you mentioned, but I'm not going to talk about it, the food shortage. I was watching on CNN yesterday and Haiti was on the list of the 55 countries. So I'll stop there.
Yeah. So in fact, I had an earlier conversation today that, you can have really fantastic drugs and therapeutics, but if you're taking them with dirty water or not the proper nutrition, they're not working the way they're supposed to. The other thing is that as you were talking, Diane, I couldn't help but think of the early days of HIV/AIDS, and it's so similar. So many things are so similar, particularly around stigma and prevention, and the idea that it's not really my problem. I don't behave this way, or I don't have exposure this way. So, I mean, a big behavior change communications campaign is something that I sort of see on the horizon. But and that has been sort of going across countries and around the world as well. So along those lines, and I'm going to head to Matt here. We know that Chorus has worked closely with ACHA, as you suggested, and for those people who aren't necessarily familiar with the African Christian Association, in Africa, most of the public health systems, and this is a wide range, but are somewhere between 30 and 80% of the health systems in Africa are actually looked after by some faith-based organization, and many of them are ACHA. So they're incredibly important, not only in the faith-based community, but just in the public health community at large. And I know that you worked very closely with them during the Ebola outbreaks. And so what thinking or systems can be leveraged with that experience for surge staffing and best practices support healthcare professionals in Africa under today's challenges?
Sure, thanks for the question. IMA World Health responded to the 2014 outbreak in West Africa and is continuing to respond to the 2018 Ebola outbreak in the Democratic Republic of Congo. It's been interesting to watch how some of the work that we did to prepare specifically in Congo has prepared us well, or positioned us well, to respond to COVID-19. From the standpoint of staffing, Eastern Congo is home to more than 100 different militia groups. It's a naturally unstable environment. And so I think when we're talking about operating in unstable conditions like that, it really demonstrates the value of building on community level health resources instead of bringing in Western outside workers. By doing that, the community trust is maintained between the health system and the communities that system serves. And that was one lesson that allowed us to continue to operate despite multiple flare-ups and even resentment of Western NGO workers in Eastern Congo. Another thing, and I would echo what Dr. John posited just a minute ago, making sure those community health workers are tapped into a system that understands how to refer cases, and then the importance of contact tracing. I've had a couple of physicians, I was in Congo last fall and during the outbreak, who stressed to me that they thought contact tracing is what beat that historic outbreak from 2018, the Ebola outbreak rather. So being able to leverage that information, centralize it, and make sure there's a coordinated response not only helps get ahead of the disease, but also empowers health workers with the knowledge and resources they need in order to do their jobs.
Yeah, thank you very, very much. So from your points, I'm hearing sort of global support, but local response is highly important. And the other thing that you brought up, which is actually beautifully segueing into our next topic, is the importance of a communication network to be able to not only contact trace, but to actually just reach out to the community in general. And there's a lot of new technology and information and data sources that are available. So I'm gonna go to Kate and Matt also, if you can chime in as well. But the information management is so critically important on every level, sort of as administrators, practitioners, program managers, so that everybody needs high quality information. And so I'm wondering if you could share with us any strategies or reflections for simplified ways of getting the right flow of information from point A to point B.
Right, there's actually a lot to unpack there. The first is that, on the internet right now, there's a lot of information around COVID. Most of it is regarding high resource settings. And so one thing that teams on the ground need is often some support to contextualize the information, to their settings. They might have a protocol from the NHS in the UK, but how does that apply to Haiti and the different drugs and equipment that you have in Haiti? So that's one set, is the contextualization. I think another important issue is also to communicate and give people the psychological support that we have to give crisis level care in many settings where you have the hot spots. You will not be able to give your standard level of care. And that actually is extremely stressful and traumatizing for healthcare workers. Like, for example, it's recently been announced in New York State, they're no longer going to do resuscitations. So basically no more chest compressions to anybody in New York State, which is just really unthinkable. But that, unfortunately, is what it's come to. And healthcare workers need to have that communicated to them, that is now the standard of care, and that is what they can do, and that is satisfactory. So that's one element of it. Another element of communication is, I think another thing that's unprecedented is how fast our information changes. With Ebola, we've been able to study Ebola for several decades, so it's understood in general. But with COVID, it's really only been a couple of months. And just to give an example, in the past few weeks, there have been major discoveries that anticoagulation helps people survive. That a lot of people are dying from blood clots. And this is not the way you usually treat viral diseases. And so the way we treat changes. And, in some populations that might make sense to put people on aspirin once they get COVID, but it's very fluid. And so with healthcare workers, you have to manage their expectations, and you have to get the new protocols to them in a way that gives them confidence to use them. And then the final thing I'll say on data, is that it's hard to get data from the systems level in most of our countries. One of the best sources is the DHIS2, which is a district health information system. Many hospitals, in fact, use this, and the open MRS, which is an electronic medical record. And so those are often some of the best sources for data in the country. But once again, that's a huge challenge, is finding accurate data of what's actually going on the ground.
Yeah, that's great. And Matt, do you have anything to add to that in terms of customizing or tailoring important resources as you work through Africa and other nations?
Yeah, just to affirm what Dr. Tolenko posited, that context is critical. I feel like what I'm hearing from my colleagues at the Christian Health Associations is we're drowning in information, but still thirsty for knowledge. And I think contextualizing as much as we can, things like job aids, things like guidance on IPC, all of that is going to be critical moving forward. One interesting thing happened, I'll share this anecdote. We had, in trying to bring together the Christian Health Association partners where we're prioritizing our response, we created a WhatsApp group because WhatsApp seemed to be the most consistent, readily available, bandwidth-friendly platform by which to share information. And we asked, what do you all need? And somebody would chime in on the WhatsApp group, oh, we need guidance on this. And then somebody from another Christian Health Association 2 countries away said, oh, I just saw something on this. We're using this here. And so we're trying to foster this cross-pollinating effect that gets the resources closest to where they need to be used and applied.
Yeah, thank you. We did just get in a couple of questions, which I'll throw to you. So I'm not sure who can take this, but so apparently there are an increased number of resignations among health workforce workers caused by fear, lack of PPE, forced displacement towards COVID health settings. So someone is asking, how would you address that? And the second question is for you, Kate, that are you saying that national or regional DHIS info is hard for individual facilities to obtain? So maybe Diane, have you seen a resignation of health workers from fear or other in your community?
No. We have not seen anything like that in our community. Remember that there are not that many jobs. Someone, healthcare provider, you resign from your job, where are you going to work? You have to continue feeding your family. So they are there, but we have seen people going on strike at the public hospital. This is a way of avoiding coming to work, because they have not been paid for like 2 or 3 months. So this is what we've seen. But in private hospital, mixed hospital, there have not been any resignation at all.
Yeah, I think though you point out that there are a myriad of economic and social issues that if and when the surge comes to Haiti, it will pile on to a whole range of other things. Kate, do you want to take, well, you could take both of those, and Matt, you can as well.
Absolutely. So certainly in Kenya, we've seen work slowdowns, and I've certainly heard reports of people not showing up to work or quitting, but usually just not showing up. And these tend to have 3 main causes. The first is people are afraid of getting infected, which is usually due to lack of PPE or lack of training. And so the solution to that is trying as much as possible to get people adequate PPE and training. And for those who are particularly concerned, maybe because they have a pre-existing condition, trying to put them in a place where they have less exposure. So someone who has diabetes, maybe they get to do telemedicine, or someone who has a heart problem, maybe they'll be taking care of non-COVID patients. So that's a way to address that. The other challenge is that of pay or hazard pay. And certainly Dr. Diane mentioned that was an issue in some public facilities. People haven't been paid in weeks or months. And the World Bank has made crisis funds available for most low and middle income countries. So paying public workers should not be an issue. We certainly know that in the Ebola crisis, that really pushed out mobile payments of health workers. For example, in Liberia, before the crisis, people weren't using mobile money, but after the crisis, it became more the standard. And so mobile money, at a time when people are worried about fomites, and cash being a fomite, it's a great way to pay healthcare workers, whether it's their basic salary or a hazard pay. And then the third issue behind a lot of the resignations is just the way health workers are being treated, that they're not being treated with respect, their voice isn't being heard. And so it's very important that hospital leaders make sure that they have a good dialogue with the healthcare workers, that they listen to them. And this is all healthcare workers, whether it's the frontline community healthcare worker, the nurse in a clinic, or your physicians in a hospital. They need to listen, and the plans need to reflect the opinions and views of the healthcare workers.
Thanks. So let me just pop back to Diane, because we do have one other question, and then I'm going to ask for some last thoughts from all of you. But Diane, I'm wondering if you could talk to us a little bit about new methods or systems of organization that you're seeing, sort of any innovations that are proving particularly helpful to your work, supporting the health workforce during these unprecedented times, that may also address some of the things that we were just talking about.
Well, innovation, for example, we were talking about the health workforce, especially the one in the remote part of the country. And Matt mentioned that it is important to have the staff working at the hospital, in the community, to be from that community or to be from that area instead of coming from far away. That's one thing that they are reinforcing and trying maybe to move certain staff to come and work in specific district to avoid traveling, using the public transport and all. The second part is the surveillance. This is really the innovation, and this is what is most important for the moment, as they are involving the cadre of community health workers, as they call them, agents de santé communautaire polyvalent. They are polyvalent community health workers, and using them for COVID-19 is going to be very innovative, and that will reinforce the system. And that is the part that is so important to stop the transmission of COVID-19. So that will be the major innovation in the health system in Haiti, that surveillance involving the community health workers.
Yeah, that's fantastic. And I think we're seeing all kinds of innovative ways to do track and tracing, and trying to improve surveillance, and bringing in all kinds of other communities. And So hopefully there'll be a pretty rich tapestry of examples around the world, and sounds like Haiti is also going to be part of that. So that's fantastic. So we do have just a few minutes left, and so I wanted to just do a quick tour de table and ask everybody within the group if you could just give 1 or 2 minutes sort of your assessment or last thoughts or reflections, and particularly now that you've become familiar with PQMD, what sorts of things can we contribute right now, and how should we prioritize the work that we're engaged in together? And Diane, I'm going to start with you first. Sorry.
Why not? Yes, PQMD. You know, one of the things we were talking about supplies and medical equipment. You know, those are the things that are really being needed. PPE needed in everywhere in the world. And you know, the wave of the surge of COVID-19 is not going to come right now in Haiti. It's going to come after the US. When your curve flattens, that's when we're going to have the surge. So that's really when we're going to need the help. So as things are being better in the US, so we should support the country in providing help, in helping us, procuring and facilitating us, finding the equipment and the supplies necessary. And also, not only that, the knowledge, the experience, the practice, the best practice, the lesson learned from the US experience, I know, and facilitate the adaptation of the lesson learned.
Yeah, no, thank you very much. As you know, that almost half of PQMD members have a long history of working in Haiti, so I'm sure you'll find the support that you're looking for. So we're excited about that. Matt.
You know, one of the reasons the coming together of IMA World Health and Lutheran World Relief really works is because the word partnership is rooted in both of our articles of incorporation. And so the idea of finding partners through PQMD that we can enact this work to support those who are the most vulnerable is a gift. And so we are open to any kind of partnership that fosters and bolsters our mission. Secondly, I would just say in lower and middle income countries, this is going to be even more challenging than it's been in some of the global north areas. And so it's going to require commitment, sustained commitment, both from unilateral, multilateral donors, humanitarian actors, corporate social responsibility actors, you name it. It's an all hands on deck event.
Yep. Thank you. Thank you very much. And Kate?
Absolutely. So I agree with Diane that in the short term, it's the PPE, the materials, the information. But as we look at the rebuild in the medium and long term, I think some of the PQMD members' experience with IT, being able to put entire nursing curricula online, entire medical school and community health worker curricula online will make a huge difference in scaling up health worker education. Also, your procurement expertise in helping new schools procure laptops, modems, simulation mannequins and equipment. And then finally, your management expertise. Health worker schools are businesses, and they need software and standard operating procedures. And most of them are not very well run from a management perspective. So the expertise that your members has will be a huge help in the post-COVID rebuild.
Thank you. Thank you very much. I see that we may have some future partnerships in our in our sites. So it's clear from today's sessions that our healthcare workers and the healthcare workforce at large are at the front lines of this battle to mitigate the impact and stop the global march of this deadly pandemic. The priority to get them the resources and expertise that they need to do their job is paramount for all of us to keep front of mind. Through the efficient use and coordinated collaboration of all the participants in this webinar and all our partners, we can bring extraordinary support and resources to bear to defeat this epidemic and stem the tide of its devastating impact. With that, I'd like to thank all of our panelists for their time, energy. I think we could have gone on for much longer, and I look forward to continuing this conversation, actually. And now I'm going to pass it back to Julie Marie. Thank you again.
I just wanted to echo EJ's gratitude and thanks to the panelists and also to all of you for joining us today. We know your time is a valuable thing. We hope that the rich dialogue and important perspectives have been meaningful to your work, and PQMD will continue to bring you webinars and host intriguing online discussions through our community of practice. We look forward to your continued participation and our collective impact in battling against COVID-19 globally. Enjoy the rest of your day, stay informed, and stay safe. Thank you.
Thank you.
Bye, everyone.